colorectal cancer screening indeed does save lives, and I think that it's an important reminder, especially here in March, Colorectal Cancer Awareness Month. As a matter of fact, one of the folks here today shared their personal story about how colorectal cancer has impacted their lives, and I'm sure that if we went around the room, there are many other stories of people suffering and dying unnecessarily from a disease that we not only know how to treat effectively, but more importantly, know how to prevent. So I appreciate the opportunity to refresh some memories and to bring some new information to some of you all. Colorectal cancer is the third most common cancer across the country and the second deadliest. Over 140,000 new cases will be diagnosed this year in the United States, and more than 49,000 people are going to lose their lives to this disease. Now, there is some good news in that over 1 million Americans are now living with a past diagnosis of colorectal cancer. Some of those people are still fighting the disease, but many of them have been treated effectively and moved on with their lives. So there is hope. And indeed, death rates have fallen steadily over the last 20 years. Now, unfortunately, as with so many things in our country, the fall in death rates is not equitable. If you see here, back in the late 70s or early 80s, both for males and females, African Americans and whites had very similar rates of colorectal cancer. Indeed, before about 1979, white males had a higher likelihood of dying from colorectal cancer. Beginning around that time, though, as you can see, there was a very dramatic fall in the colorectal cancer death rates among the white population. Rates continued to rise in African Americans for about another 5 or 6 years, and then they've begun to fall as well. So we have falling rates in both populations, but because the fall in the white population is so much more dramatic, we have a worse disparity in this disease than we've ever had. So figuring out some of the reasons behind this disparity is one important part of the work that I do on behalf of the Cancer Society. Now, there are a number of different things that account for the falls that we're seeing. Clearly, we've made some significant advances in treatment. There are 3 drugs that are now used to treat colorectal cancer that weren't in the marketplace 10 years ago, and those drugs have made a very important improvement in the ability to affect the disease. Screening leading to cancer detection at an earlier stage and allowing those drugs then to have a better chance to work has also contributed to this fall. But probably more than anything else, screening and removing polyps has led to preventing those polyps turning into cancer. And as a matter of fact, a study published about a year ago in the New England Journal of Medicine estimated that at least that polyp removal was associated with at least a 50% reduction in the likelihood of people dying from colorectal cancer. Let's talk about some risk factors for the disease. There are a number of non-modifiable risk factors. We don't get to choose our parents, as people say. And my kids at times were very unhappy with that. But a family history of colorectal cancer or adenomatous polyps increases one's risk very significantly. A personal history of adenomatous polyps or a personal history of colon cancer in the past also increases your chance of having another colon cancer. There also are a number of genetic syndromes, FAP, HNPCC, that increase risk very strikingly. Individuals who have any of these risk factors actually are in such a high risk group that they require different kinds of screening. So people with these sort of risk factors may need to begin screening at a much earlier age and may need more intensive screening. So it's important to try to assess family history when you're interacting with people so that you can pick out those folks who need to start screening or may need more aggressive kinds of screening. For instance, an individual who has a family member diagnosed with colorectal cancer at age 52 or 53, instead of waiting until they are age 50, as is the case for average risk folks, they need to start screening 10 years younger. So they would need to start screening in their early 40s. Now, I'm going to focus the remainder of my remarks on screening in the average risk population, but it's important to keep that in mind. You need to find these folks who have these risk factors and make sure that they get dealt with more quickly or earlier. Now, all of those risk factors that I just talked about are certainly important, but the number one risk factor for developing colorectal cancer is age. Simply being over the age of 50, the risk begins to rise very dramatically, and the longer you live, the higher the risk. So age is the most important risk factor, and 90% of cases occur in people who are 50 and older. In terms of gender, there is a slight male predominance, but really this is an equal opportunity killer. So women need to understand. Unfortunately, if you talk with women, a lot of women perceive this as a man's disease. And I think part of that is because we've done such a good job over the last 15 or 20 years at reinforcing the importance of mammograms, reinforcing the importance of pap smears. So they know they're supposed to have those tests, but they haven't been hearing those same messages about colorectal cancer screening. Thus, they don't think it relates to them. There are also some racial and ethnic differences in disease risk. African Americans for many years were said to have the highest rates in the United States. And as I showed you before, in terms of mortality, the rates certainly are strikingly higher than the white population. Incidence rates are much higher as well. However, as we've collected better data on other populations, we found that some Native American populations, in particular Northern Plains Indians, have very high rates. Alaska natives also have very high rates of colorectal cancer. So there's some data now suggesting that the rates among those groups may be even higher than among African Americans. And then Ashkenazi Jews also have very high rates. The reasons for these racial and ethnic differences right now are unknown. We don't have any clear marker that gives us a reason why, but we do know that these differences exist. So again, when you're interacting with patients, making sure that they're aware. Now, these risk factors at present are not thought to rise to the same level, for instance, as having a family history of the disease. So people with these risk factors still fall into the average risk screening population, but it's particularly important that they do start to get screened. There are also a number of modifiable risk factors, things that we can do something about. Diet being one, a diet that's high in red meat, high in processed meat, like lunch meats and hot dogs and those sorts of things, increases the risk very significantly. Tobacco, alcohol, drinking more than one drink a day in women or more than 2 drinks a day in men increases risk of developing colorectal cancer. Physical activity is actually protective, and it's protective in a dose-response way. That is, the more you exercise, the more physically active you are, the greater your risk reduction. So staying physically active is one way to cut your risk. And then obesity also is tied to colorectal cancer, both the risk of being diagnosed and the risk of dying from the disease. And like physical activity, obesity, the larger you are, the greater your risk rises. Polyps. I've mentioned polyps. Polyps are little asymptomatic nodules or growths that occur in a lot of parts of the body, but we're talking about colon polyps today. Colon polyps grow in the lining of the colon. They usually cause no symptoms. People don't have any pain or discomfort in early stages, or actually until very, very advanced stages. There's no bleeding, so there's no way that people can know that these are existing. But they have a tremendous negative potential. There are 2 main types of polyps. The first type are called hyperplastic polyps. And fortunately, hyperplastic polyps in general have very little cancer potential. Thus, if an individual has a colonoscopy and all that's found are a couple of small hyperplastic polyps, that person is still felt to be at average risk for developing colorectal cancer, and therefore they don't need another screening colonoscopy for 10 years. On the other hand, adenomatous polyps have a much higher likelihood of transition to colon cancer, and it's thought that about 90% of the colon cancers we see each year in the U.S. are related to adenomatous polyps or arise from adenomatous polyps. Adenomatous polyps are also quite common. There are targets for endoscopists, people who are doing colonoscopy, as one quality measure, are asked to record their adenoma detection rate. That is, what percentage of patients that they do colonoscopies on are found to have adenomas. A good adenoma detection rate is felt to be 25% in men and about 20% in women. So that is for everyone 50 and older that person does a colonoscopy in, they should find a polyp in 1 out of 4 men and 1 out of 5 women. So that's how common these growths are. But while the adenoma certainly is challenging and that it does have tremendous cancer potential, the transition from here, a normal inner lining of the colon, to a large polyp, to invasive cancer, takes a long time. The transition time is anywhere from 7 to 10 to as long as 14 or 15 years for this to happen. So that means you've got a very long window during which you can find and remove that polyp and keep cancer from occurring. So while the polyp is concerning, the polyp's also our friend when it comes to colorectal cancer screening. It tells us who's at risk, it gives us a target to remove, and it tells us who then needs to be followed up more frequently or more regularly to cut the risk of dying from colorectal cancer. So when we talk about screening, there are some very clear benefits from colorectal cancer screening. One, as I just mentioned, removing polyps, preventing cancer. 2, colorectal cancer screening is very cost effective if you compare it with the cost per life saved or any other way of looking at cost effectiveness. It compares very, very nicely with mammography or other cancer screening and other kinds of preventive services. And indeed, most of the estimates of cost effectiveness of colorectal cancer were done 10 years ago or more before these newer drugs came into the market. As I said, we've got some new, much more effective drugs available to treat colorectal cancer, but like most new things, those new drugs are much more expensive than things that were used in the past. So treating advanced colorectal cancer with these more expensive drugs is a very expensive proposition, and finding it in early stages or preventing it altogether is even more cost effective than we probably are aware. And then finally, we can improve survival very significantly. Even if we miss the opportunity to find and remove that polyp, if we catch cancer early, as has been shown to occur through screening, we can cut death rates by major degrees. This blue bar here on the left is the 5-year survival for people whose cancer is diagnosed at the early stage. That is, they have cancer, not a polyp. They had cancer found, but that cancer is confined to the lining of the colon. It has not begun to penetrate the colon wall. 9 out of 10 of those people are going to be alive 5 years later. 9 out of 10. Contrast that with the red bar here. These are people whose disease has spread to other parts of the body by the time they're diagnosed. 10%, only 1 out of 10 of those folks are going to survive for 5 years. 90% survival versus 10% survival. Huge difference. The problem is patients just aren't aware of that. And as a matter of fact, a lot of primary care clinicians aren't familiar. They don't understand how big a difference we can make, not only by preventing cancer, but by finding it early. So how are we doing when it comes to screening? These bars show the progress in the U.S. across the entire population between 2000 and 2010 in terms of colorectal screening rates. So back in 2000, about 39% of adults age 50 and older were up to date with colorectal cancer screening. As you can see, there's been a steady rise in that. And as of the most recent data from 2010, 59%, or basically 6 out of 10 adults, are up to date. Now, some people, if you're not familiar with population statistics, going from 40% to 60% over 10 years may not seem like it's, well, yeah, it's some progress. But if you think about the entire population at risk of the United States, making this sort of jump over a 10-year period is really very impressive. So we're doing something right, but we're still not doing it well enough, because a 60% up-to-date rate means 4 out of 10 adults who are at risk of the disease are not up to date with their screening. So We've made progress, but we still have a long way to go. And unfortunately, like most things in society, there is a lack of equity along a number of axes. One is education. Individuals who lack education or had less than a high school education started out at a much lower rate, 26% back in 2000. And that rate has risen, but they're now at about 44%, which means more than half of people with less than a high school education are not up to date. But most striking is the issue of health insurance. There has been almost no change in the likelihood of people being up to date with screening over this 10-year period. We've seen this sort of rise among the population at large, but if people don't have health insurance, they don't get screened. So regardless of one's political leanings, the idea of providing health insurance for everyone in the population, I think, has to be considered. In addition to the differences along education and insurance, there also are racial and ethnic differences in the likelihood of people being screened. The white population having the highest rates, African Americans trailing by a significant degree, especially when you think about higher rates of incidence and death in the African American population. Hispanic Latinos, much lower, but this also strikes me, given that, as I said, the data now shows that these populations may have the highest risk in the country. The fact that they've got the lowest screening rates says we've got a lot of work yet to do. And the Asian population also trails. Though the black-white difference in screening rates, among other things, probably accounts for the fact that we've seen significant improvement, again, in 5-year survival. This is for all groups, all stages of disease. 5-year survival back in the mid-70s was about 50% for the white population, and is now basically 2 out of 3 individuals who are diagnosed with colorectal cancer, whatever stage, will be alive after 5 years. The African American population survival rate has risen, but again, trails far behind. So we have significant, we've made progress, but we've got a long way to go. I've talked about screening. Let's talk specifically about the screening tests. So which tests are available? These are ACS guidelines, actually, that were published in concert with the American Gastroenterologic Association and other GI organizations, as well as the American College of Radiology. We brought all of these organizations together back in 2007 and 2008 so that everyone could be on the same page with regard to colorectal cancer screening. One of the things that we heard, particularly from clinicians, was, well, this body says this and somebody else says that, and we don't know what to do. So we got everybody together, and we all gave the same message for a little while. Coalitions are hard to maintain, and some of the organizations have kind of gone rogue since this time. But as you can see, this is a lengthy list. We actually went into the process anticipating that we would be able to abbreviate the list that we had at that time, and we ended up instead expanding it and adding new tests. And then less than a year later, the U.S. Preventive Services Task Force came out with their recommendations, and again, we had differing recommendations. But what we can very consistently point to is, while there are some differences between the ACS and Preventive Services Task Force and GI organizations, there are the commonalities are much more important. And the commonalities are all of these organizations recommend fecal occult blood testing as an option. They all recommend colonoscopy and flexible sigmoidoscopy as an option. Now, there have been studies published over the last 2 or 3 years, both from the UK and from the US, that show that sigmoidoscopy is actually a much better screening tool than it's been given credit for. The reality is, in the US, you can not find a flexible sigmoidoscopy in most major cities. It just is not readily available. When you get to some smaller towns, and there may be a few primary care clinicians who are still doing them, but it's very, very rare and difficult to find. So it is effective technology, but hard to use. So in the US, what it really comes down to is colonoscopy or stool testing. Those account for probably 95% of the colorectal cancer screening that we see every year, with more than 80% being colonoscopy. Now, one question is, what test do patients prefer? I gave this talk somewhere else, and the answer was none of the above. The reality is Many clinicians, many primary care clinicians in particular, automatically say colonoscopy. You should have a colonoscopy. Colonoscopy is the best test, and therefore go get a colonoscopy. And that's the message that they consistently give. What they don't recognize is that patients do have preferences. And patients are, in many instances, reluctant to push back against their physician. So if the doc says, go do this, they're going to say, okay, and they'll take the appointment slip. But then nothing happens. Investigators looked at this issue and published this study last year. They took a group of patients and they put them into 3 pots. One group was offered only stool testing for occult blood. The second group was offered only colonoscopy. And the third group was said, well, you need to be screened. These are your options. You can have a stool test or a colonoscopy. What they found was, of the group that was offered only colonoscopy, 6 months later, only 38% of those people had completed that test. Of the people who were offered only stool testing, 2 out of 3, 67% had completed, and a similar completion rate for those who were given a choice. So while clinicians feel that colonoscopy is what everyone should have, clearly patients don't necessarily feel that way. And it's therefore important to recognize that and to find out what patients want. Recognize that there are some patients, when I was in practice, I tried to promote prevention. And I remember very vividly talking to one older woman about the importance of colorectal cancer screening, and we have this test called a colonoscopy, and she said, you want to put what? Where? I ain't having no problems, no thank you. Offering an option, something, I mean, the idea of a colonoscopy just sounds horrific. What patients don't understand is they're not going to feel that. 90% of the time, they are either completely asleep or they're so relaxed that they're not feeling it. But just the idea, getting past that idea that you're going to put this long tube, it just sounds terrible. And a lot of people can't get past that idea. But talk to them about, you know, this is something you can do at home. You don't have to go see any specialist. You just collect these cards or collect this little specimen and bring it back to the office. Is frankly much more acceptable to people. But if you don't let them know that there are options, then nothing gets done in many instances. So I'm going to talk briefly about colonoscopy and stool testing. Colonoscopy, everyone is likely familiar with. It's a long lighted instrument with a camera and a light on the end that is inserted in the rectum and goes all the way through and views the entire lining of the colon. For that reason, colonoscopy certainly has some advantages relative to other forms of testing. One, you're looking directly at the entire colon. This is the view through a colonoscope as you're moving through. Two, it has not only screening potential, but it is diagnostic in that if you see an abnormality, if you see something that looks strange, you can take a little biopsy and send it off to the lab. Or if you see a polyp, it's actually therapeutic because you can remove most polyps through the colonoscopy. So you get screening, diagnosis, and treatment all in one test. So certainly that has the potential to be advantageous. And colonoscopy is clearly a good test. But is colonoscopy the best test? Is it the gold standard? Is it the perfect test? And I would argue no, for a number of different reasons. One, colonoscopy is overestimated. The accuracy of colonoscopy is markedly overestimated by many primary care clinicians. They think the likelihood, because you're looking directly at the lining of the colon, you're not going to miss anything. The reality is colonoscopy will miss up to 10% of significant abnormalities, that is, large polyps or cancers. And this was proven in 3 now studies of back-to-back colonoscopy or colonoscopy and CT colonography. Let me ask, anybody here willing to go through 2 colonoscopies in one day to prove the principle? That's what they got people to do. I'm still amazed at that. I go in and do a colonoscopy, then I leave, and then my colleague, Dr. Henry Tillman, comes in and she does another one on the same patient. But they got people to agree to that. I think they must have paid them. And well, but at any rate, those studies showed that up to 10% of significant abnormalities, not just little tiny polyps, but significant polyps that had cancer potential or cancers were missed through those studies. There also is a much higher incidence of injury to the colon or injury to the patient. Colonoscopy is a very safe test, but bad things can occur. You can poke a hole in the colon, what's called perforation. That's more common if a polyp is removed, if a biopsy is done. But many people also have cardiovascular events. Realize we're talking about screening in older people, 50 plus. Many of these folks are 60, 65, 70 years old. If they've got any sort of unknown cardiac disease, they're at risk. So strokes and heart attacks are not uncommon after a colonoscopy or during the course of the procedure. It's estimated that about 1 in 1,000 people undergoing a colonoscopy will experience a complication significant enough to require additional care. Now, again, for most of those folks, we're not talking about them dying, but dying as a result of colonoscopy is not unheard of. So it's important to keep that in mind when you're talking with patients about having this test, because remember, these patients are coming with no signs or symptoms of disease. They're not having any problems. And to have someone end up with a hole poked in their colon or a heart attack as a result of this is not something to be taken lightly. In addition, colonoscopy is significantly more costly on a one-time basis. I was in Iowa yesterday, and a gentleman related the fact that his wife had recently undergone a colonoscopy, and the total bill for all of the related services for a screening colonoscopy was almost $5,000. Now, they have insurance, so their insurance had negotiated it down to about $3,000, and then their copay was, much smaller than that. So their actual out-of-pocket cost ended up being relatively reasonable. However, if you don't have insurance, that $5,000 bill is yours. So that can be a real barrier for folks. Or if you have bad insurance, much or all of that bill may be yours. In addition, the colonoscopy is what we call operator dependent. It's highly operator dependent, meaning that each colonoscopist has their own level of skill. And there are some colonoscopists who are very, very good at seeing everything or most things that are there. And there are others who, in spite of having done 100, 200, 300, simply aren't as proficient at finding that. I mentioned the adenoma detection rate earlier. There are a number of studies in the literature now showing that you can take a group of gastroenterologists, people who all work together, and measure the adenoma detection rates, and you can have spreads between 25% is the target in men. You'll have some people in that group who are finding adenomas in 30% of men, and other people in the same group who may only be finding them in 12 or 15% of men. Now, it's not likely that their patients are that different. Their skill and ability to find those adenomas is very different. So that sort of operator independence means that you need to kind of know what the skills of your endoscopists are. So one of the things that I always encourage people to do, if you or someone that you know is going to have a screening colonoscopy, ask that colonoscopist, what's your adenoma detection rate? And if they don't want to tell you, or if they can't tell you, if they're not tracking that data, you might want to look around a little and see if you can find someone who can tell you, well, this is what my skill level says based on objective measures. Other things about colonoscopy. There are greater patient requirements for getting this test done than for any of the other screening tests. I mentioned the procedure and sedation. So one, you've got to be well enough to undergo some form of sedation. But sedation also adds an additional wrinkle, which means that every center that I'm aware of requires that you have someone bring you and take you home after the procedure. So you've got to have not only you, but you've got to have somebody accompany you for that, which is a big problem for a lot of people. And in addition, the necessity for taking time off of work to get the test done. Most centers are not operating evenings and weekends. And then finally, the prep. The the procedure is much less than what people anticipate. The prep is usually a lot more than people are anticipating. And I've had numerous patients tell me, Doc, I'd be happy to have a colonoscopy again. That was nothing, but can you do something about that prep? Oh my goodness. There is a lot of work going on trying to simplify the prep, putting people on simpler diets for 2 or 3 days, low bulk diets, and then using less caustic materials to help clean out the colon. And there's some progress being made, but for the most part right now, the prep is still a pretty ambitious undertaking. And again, we think about older people, people in their 60s or 70s, just dealing with that issue is a challenge, and then add in diabetes. So now what do they do with their insulin, and how's their blood sugar stay controlled? So it can be pretty complicated. Access to colonoscopy may be extremely limited. I told you about the cost issue. Insurance has in the past been a problem, but is less so. I'll talk about that a little later. But colonoscopy resources may be limited in many environments. I'm sure here in Little Rock, we probably couldn't throw a stone without hitting an endoscopist. But if you go 50 miles in either direction, or a couple of 100 miles, those people may have to drive a couple of 100 miles to get to the procedure. And then finally, the patient preference issue, which I already mentioned. So for all of these reasons, colonoscopy is a good test. I don't want anyone to feel that I'm downgrading colonoscopy in any way, but I'm simply saying it's a good test, but there are other good tests. So I'm going to talk now about what are viewed as other good tests that have good evidence supporting their use and that are in common use. Stool testing. The stool test that I'm talking about look for hidden blood in the stool. They're called fecal occult blood test. And there are 2 main forms. The first form is the Guaiac test, and this has been around probably 60 or 70 years. This is the type of stool test that was used in major trials that prove colorectal cancer screening could decrease incidence and death from colorectal cancer. Many people don't appreciate that. There's often the perception among primary care clinicians that if they're offering stool tests to their patients, they're giving them something inferior. But this actually has a very good evidence base. The Guaiac test requires 3 specimens be collected from 3 separate bowel movements. The Guaiac test also is non-specific. That is, if there is bleeding, suppose someone had a heavy nosebleed and swallowed some of that blood, or if they have an undiagnosed ulcer or gastritis that's causing bleeding in their upper GI tract, that's going to show up positive on a Guaiac test. Guaiac tests also are highly influenceable by medications as well as diet to some degree. So there are things that you can eat or meds that you can take that can cause it to be either false positive or false negative. So Guaiac test is a good test, but it has some significant limitations. The biggest limitation, however, is a lack of current practitioners keeping up with technology, because there are newer forms of the Guaiac test, Immunochemical, Sensa, and I was told yesterday about another test, I can't remember the name, but these are Guaiac tests, but they have higher sensitivity than the tests that were used in the original trials or the most common test. The most common Guaiac test still out there in common usage is called Immunochemical 2. And the difference in sensitivity between Immunochemical 2 and the newer version, Immunochemical Sensa, is almost twofold. That is, Immunochemical Sensa is almost twice as likely to find cancers as Immunochemical 2. Yet there's been very little movement in the clinician community toward that newer form of Guaiac testing. The other kind of fecal occult blood test is an immunochemical test. The immunochemical tests are newer. I believe they were initially introduced maybe 20 to 25 years ago. There was an effort here in the US to get them into play, and it never really caught on. So they disappeared from this market, but they have been used very heavily in Asia, in particular in Japan, over that entire span. And after showing a lot of good results, over the last 10 to 12 years, there's been a marked increase in the use of fecal immunochemical tests here in the US. The fecal immunochemical tests are much more sensitive than the older Guaiac tests. They're at least as sensitive as Immunochemical Sensa, the newer version, and maybe even a little more sensitive than Hemoccult Sensa. In addition, they are not impacted by food or medication, so you don't have to worry about the false negatives and false positives. And also, they are specific for bleeding from the lower GI tract. The test looks for a different portion of the hemoglobin molecule, a portion of the molecule that is damaged as it's passing through the GI tract. So if you have bleeding from your stomach or that heavy nosebleed or something that I talked about earlier, as that's going through your body, it gets changed in such a way that this test does not detect it, so it won't show positive. If you have a positive fecal immunochemical test, it's highly likely that that's because of bleeding in the lower GI tract. So for those reasons, the higher sensitivity, the higher specificity, the lack of interference by food and meds, a lot of larger entities are switching toward fecal immunochemical testing. And indeed, two of the major reference labs in the country, LabCorp and Quest Labs, have stopped offering any type of Guaiac testing and provide only fecal immunochemical testing. Unfortunately, this is not well known by many clinicians yet, but using this form of test or the high sensitivity Guaiac test, Hemoccult Sensa, will increase the sensitivity, increase the value of a program of screening with stool testing. Now, there are some quality issues associated with fecal occult blood testing that have to be addressed. One of which is there's a tendency on the part of many primary care clinicians to say, I gave the patient the cards to take home, or I gave them the kit, and they never collected a stool specimen. So while they're in the office, I'm going to do a rectal exam, and I'll check that stool. And if that's negative, they've been screened for colorectal cancer. Well, for many years, it was suspected that's probably not as effective as collecting multiple specimens at home. But we didn't have the proof until a few years ago. This study looked at about 1,200 patients who were scheduled for screening colonoscopy. So these people had no signs or symptoms of disease. They were a screening population. And prior to their colonoscopy, these folks were given the 3-card take-home Guaiac test using the old version of Hemoccult, Hemoccult 2. And then prior to the colonoscopy, they had an in-office digital rectal exam, and the stool was smeared, and they checked that. And they compared the results of each of these, the single sample in office, the 3-card take-home, and then compared that with the colonoscopy findings. And what they found was the 3-card take-home test found 24% of all lesions, that is polyps and cancers. And if you narrow it to just cancer, the 3-card take-home test found 44% of cancers that were seen at the time of colonoscopy. The single sample in-office test found 5% of all abnormalities and only 10% of cancers. So if patients had seen their doctor, had that single sample in-office test, it was negative, 9 out of 10 people who had cancer would have been told, oh, that's fine, you're doing well. This was, in our minds at ACS, should be the final nail in the coffin of that form of testing, that single sample in-office testing. Unfortunately, the National Cancer Institute has done surveys over a 10-year period, and going back about 10 or 12 years ago, about 30% of primary care clinicians were doing that in-office test as their main approach to testing. After this study was published about 3 or 4 years ago, they repeated that survey, and the number had dropped, but still about 20% of primary care clinicians are using that single sample in-office test as their main approach. So 1 out of 5 clinicians out here are doing a test that is going to miss 9 out of 10 cancers. Now, these numbers are not great. Only 25% of all lesions and 44% of cancers. A couple of things. One, as I mentioned, the study was done using the older form of Hemoccult. So using Sensa or using an FIT, we suspect that the results would be even greater. But the other thing this does is reinforce the fact that stool tests are going to miss some polyps and are going to miss some cancers, which is why it's important that that stool test be done every year. If someone decides that they want to do stool testing, not have colonoscopy as their screening approach, that stool test needs to be repeated every year. And it's up to both the patient and the clinician to make sure that it's done. And if you're doing it year after year after year, the chance of finding either the polyp before it transitions to cancer or the cancer at an early stage is much higher. So there are a number of different stool test quality issues that we've outlined that need to be taken into account. One, the in-office test has to go. So if you are interacting in any way with clinicians, if they can make only one change in their practice, getting rid of that is step one. Step two is getting practices to use high quality stool test. So Hemoccult Sensa or the fecal immunochemical test. 3, testing needs to be done annually. And 4, all positive tests need to be followed with colonoscopy. Unfortunately, there has been a tendency at times, if someone, say, is given 3 Guaiac cards to take home and they bring it back and only one of those 3 is positive, the clinician and or the patient will make excuses. Well, then maybe I had some hemorrhoids, or maybe I took the wrong medicine. Let's just do the stool test again. Absolutely wrong. Any positive stool test needs follow-up with colonoscopy. So these are the basic parameters of a high-quality stool screening program. We outlined these and some of the research and information supporting that in a one-page front and back document that I believe you all have, or they're here on the front table if you didn't pick one up on the way in. Pick up a couple on the way out and share them with your practicing colleagues. All right, so I want to shift now to improving screening rates in practice. Now, why are screening rates low? Why is it that at this date still 4 out of 10 people who have insurance, who don't have other kinds of barriers, are not up to date with screening? The ACS and others have done a lot of work around this. We've done surveys, we've talked to people, and what we found is, one, there's a low awareness of colorectal cancer as a personal health threat. People do know about colorectal cancer now. Contrary, when I came to work for the ACS 13 years ago, overall awareness of colorectal cancer as an important health issue was fairly low. But probably the biggest change occurred after Katie Couric her husband died, and she went on the air and had a colonoscopy on air. And then she followed that with a lot of public service announcements and has funded an organization. She also, a couple of years later, underwent a CT colonography on the air. So if one person can get credit, certainly Katie Couric helped jumpstart the media awareness around colorectal cancer. And since then, information's everywhere. March is Colorectal Cancer Awareness Month, and there is almost always something in the newspapers. There's all sorts of things going on. So people know about colorectal cancer now, but they still don't personalize it. Well, I don't have anybody in my family who has it. Or I'm not having any symptoms, so yes, it's important, but it's not important to me as an individual. There's a lack of knowledge about the screening benefits. When you talk to patients about doing a screening test and preventing cancer from occurring, they never heard of such. That doesn't happen, that's witchcraft. Talking about finding cancer early and a 90% versus a 10% survival rate. Patients just aren't aware of those kind of numbers. So patients need to understand the value in order to follow through with recommendations. There also is fear, embarrassment, discomfort. This is a part of the body people don't talk about. All my years in practice, I can't think of more than 2 or 3 times where anybody came in and pointed at their butt and said, I'm having a problem here. It just don't. And including people who were clearly having problems. There were times that I would ask to do a rectal exam for one reason or another and find some horrific things that people just lived with. So certainly, if they're not having any problems, they're not talking to you about this. There are time, cost, access issues. We've talked about all those. There are structural issues, a lack of systems. And that's what I'm going to be talking about moving forward, is systems. But what do you think is the #1 reason people give us that they weren't screened? We talked to a group of people who have not been screened for colorectal cancer over and over and over again. My doctor never talked to me about it. They are waiting to hear from their clinicians. They figure if it's important, their doctor will tell them to do it. And if their doctor didn't say do it, then it must not be important. Conversely, if you talk to people who have been screened for colon cancer, many of them will say, well, I had a family member, or I saw Katie Couric, but many will also say, well, my doctor said to do it, so I figure that's what I'm supposed to do. So we have to get clinicians talking to their patients about this. Unfortunately, this is the perception that many clinicians have about talking to their patients about colorectal cancer screening and think, oh, it's worthless. They don't want to hear it. They're not going to do it. But the reality is that the most consistent, influential factor at getting screened for colorectal cancer is that clinician recommendation. Unfortunately, what happens now, though, is opportunistic as opposed to organized preventive care. This is not just for colorectal cancer screening, but colorectal screening gets caught up in this. And that is, number one, medical practice is demand-driven. Patients come in because they want their diabetes checked, they need a refill on this medicine, their back is hurting, they've got a cough. So the clinician is dealing with those demands. And preventive care is something that gets worked in if there's time, if the clinician thinks about it, if the patient is receptive. So we end up getting some patients getting some of the tests they need some of the time, but getting everyone in a practice up to date with all of their preventive services is a rarity because we simply haven't systematized it. We've left it a one-on-one. The American Cancer Society worked together with a consortium of organizations, the National Colorectal Cancer Roundtable, and some researchers at Thomas Jefferson University. A number of years ago, we recognized that primary care clinicians needed some insights into how they can make practice changes that would improve colorectal cancer screening. So we got the researchers together, and they did a wonderful job, but as academics are prone to do, they maybe a little much. This complete guide ended up at about 130 pages. A lot of deep, detailed information about screening, a lot of resources. So it is a wonderful compendium of everything out there, but you give it to the average practicing clinician, they say, well, this is great, but I don't have time to deal with this. So we went back to the drawing board, and about 2 years ago, condensed all of that information into an 8-page guide that we call our action plan. And this action plan takes the same concepts and principles that are the core of that larger detailed guide and condenses them and summarizes them in such a way that it's easily understandable and hopefully can start guiding a practice toward how to make changes. And then the detailed guide is there available for them in support of any of the pieces of this that they're interested in. Both of these guides are developed around what we call the 4 essentials. And there are 4 essential elements of practice change. If you implement these changes, you can see significant improvement in your screening rates. Number 1, the recommendation that I just talked about. Getting at clinician recommendation is key. And as part of that recommendation, knowing who needs the recommendation and at what point, which means getting family history. So you need to know not only who's over 50 in your practice, but who's under 50 but has a family history of the disease, and they need to start screening earlier. Having a screening policy. Let's see, let me zip through these. Okay, so in terms of recommendation, knowing exactly what you and your staff are going to be saying to patients about getting screened and recognizing who may need earlier screening. Screening policy, having a standard course of action that everyone in the practice abides by. And everyone doesn't just mean the clinicians. You need to have the rest of the staff engaged as well. The nurses, the front desk staff, everyone needs to understand colorectal cancer screening is a priority in the practice, and here's your role. This is your piece of this pie. You need to know what the resources are that are available in the community. You need to, if possible, know the adenoma detection rate of the various colonoscopists and figure out who you're going to send patients to. And you also need to know, for instance, if you're doing stool testing, what kind of stool test is used in your practice. Now, when I ask a group of primary care clinicians about this, most oftentimes the response I get is, I have no idea, because someone else does that. Somebody else does the purchasing. I just use whatever's there. But whoever is doing that purchasing doesn't know that there's a lot of difference. So they're making that decision based solely on price, whatever they can get the best buy on. But if it costs a few cents more, but you can double the sensitivity, you need to look at shifting over to using a higher sensitivity test. So other things that need to go into your screening policy, again, how you're going to evaluate each individual's risk level and make sure that you identify those folks who need earlier screening, knowing what the resources are in your community, knowing where colonoscopy is available, knowing where low-cost or no-cost colonoscopy is available for your uninsured or underinsured patients. Addressing the patient preference issue. So even if your practice decides colonoscopy is going to be our main approach to screening, there should still be a message about fecal testing so that patients know that they have a choice, so that their preferences can be addressed. Knowing what state and federal programs are in play that may allow your patients to get access to screening that might not otherwise have it. And then very important, the insurance issue. Something that a lot of people aren't aware of, a lot of patients in particular, but even some clinicians. As part of the Affordable Care Act, part of it that's already gone into effect, any test, any screening test that has a or B rating from the Preventive Services Task Force is a no copay, no deductible test. So patients, and this is in private insurance plans as well as in Medicare, so patients have access to mammography, colorectal cancer screening, cervical cancer screening without the requirement to pay a copay or deductible, which is huge. But there was a loophole in the initial rules that came out. And what would happen is patients would go in for a screening colonoscopy. If during the course of that colonoscopy a polyp was found, and the polyp is removed, suddenly that became a diagnostic procedure, and they would then be charged a copay for that procedure. A lot of patients woke up and got very, very mad at their gastroenterologist because they had been told that this wasn't going to cost them anything. Fortunately, as of 2 weeks ago, the Health and Human Services Department published new rules and closed that loophole in the private insurance market so that now a polyp removal is considered part of the colonoscopy, and plans cannot impose cost sharing. If that colonoscopy began as a screening procedure, it ends as a screening procedure. So this is a real win. Now, unfortunately, that has not yet moved into the Medicare population, but hope there actually, I learned yesterday there's been a bill introduced into the House, the U.S. House of Representatives, to try to address it. Okay, so reminders. Reminders are the third essential. Reminders are both to patients, and patient reminders are a couple of different types. You can either use what are called cues to action or educational materials and information. And this, for instance, is a patient education video that was developed by the Cancer Society. It talks about all of the major forms of colorectal cancer screening. It talks about why the test is important and necessary, and actually shows people what it's like to go through a colonoscopy, shows them how to collect a stool specimen in a very basic way. This is about 7 minutes long, and it's available in both English and Spanish. And this is the sort of patient education tool that, that you can put in place. There also are clinician reminders, and a large number of types of clinician reminders. But the basic thing is you can't leave it up to the clinician to recognize each patient who comes through the practice is going to need screening. And again, that's where it comes into bringing the entire practice into this, so that whoever is at the front desk when that patient checks in, they can simply look at their chart. Oh, you're 50 or 51 years old. Have you ever had screening for colorectal cancer? Not sure? You don't know? Talk to the doctor about it. Just putting a little sticky on the chart, something that simple and basic, can lead to improvement in screening rates. Now, more sophisticated use of EHRs, for instance. If the system has a good electronic health record that tracks this information, then using EHRs to pull lists of who in the practice is not up to date with screening and focusing on that group of people. But some sort of reminders to make clinicians aware. And then finally, measuring progress. The first thing a practice needs to do if they're thinking about changing their colorectal screening rates is find out what their current rates are. You'd be surprised how many people launch into a quality initiative and don't know what their baseline is. So you need to do that. And again, if you have a good, effective EHR, that can make it very easy. But unfortunately, from my conversations with clinicians around the country, most EHRs, particularly for smaller group practices, don't do a really good job at pulling out information about colorectal screening. Part of that is because you've got, you know, an annual stool test, a stool blood test, or you've got a 10-year, every 10-year colonoscopy. So that information isn't always captured, or it's not there in such a way that it can be searched on. So doing very simple chart audits, just pulling a chart on 12 or 15 patients who are over the age of 50 and going through, seeing whether there's evidence of colorectal cancer screening documented in those charts will give a very good idea of what your baseline screening rate is. Then implement these issues, have that recommendation in place, engage the entire staff in getting that recommendation out, and use the reminders and find out how things are working, and ultimately you can see some changes in your practice. Let's see. So again, the 4 essentials: recommendation, screening policy, reminders, and then measuring progress. Practices that implement these 4 features, or that, you know, strongly implement. Maybe you take them one at a time. You figure out what your screening policy is and get everyone engaged. A key to making this happen is having the entire practice engaged in this, so it's no longer up to the clinician to remember on a one-on-one basis. All of the materials that I've talked about and many, many more are available at the American Cancer Society website. There are a number of different versions of the toolkit that I've mentioned that are available at the websites mentioned here, and a lot of other resources. We have all of our colorectal cancer resources at one site here, cancer.org/colonmd, and then we have resources for anything related to cancer that health professionals would be interested in are housed at this site. So I thank you all for coming today. Thanks to you all on the phone who hung in there, and I'll be happy to entertain a question or two if need be. Yes?
The 3D CT machine.
Yes.
At one point when they first came out, they talked about doing colonoscopies, you know, looking at the bowels that way.
Yes.
What do you know about what's going on with that now?
Okay. CT colonography is using X-rays to look at the lining of the colon. And CT colonography is really very cool technology. It was designed in part based on video game technology. You ever, you know, steer your starship through the stars or ride that race car on a racetrack? Well, some very smart radiologists and computer folks came together and said, okay, we'll take pictures of the entire abdomen, we'll single out the colon, and we'll look at the lining of the colon. And then you can just sort of drive through the colon, looking at the entire lining of the colon wall using this. So it's really very cool to look at if you ever see one. CT colonography, from the perspective of the American Cancer Society, actually is an effective approach to colorectal cancer screening. There have been, at the time that we did our last guidelines, there had been 3 large studies that had looked at it and showed that it was, for finding cancer, it had about the same detection rate as traditional optical colonoscopy. For finding large polyps, not quite as good. Finding small polyps, not very good at all. But for finding cancer in large polyps, we felt that it was deserving. So it's included as a recommendation to ACS guidelines. The Preventive Services Task Force looked at the same data and said, well, it looks good, but we don't have enough evidence right now. That was 5 years ago. Since that time, a number of additional studies have been published, all of which show CT colonography to be very, very good. And I anticipate that the Preventive Services Task Force, whenever they do their colorectal cancer screening guidelines again, would have difficulty saying that the evidence is not sufficient. But because of the Preventive Services Task Force saying that it's not ready yet for wide acceptance, Medicare and a number of other insurers do not yet pay for it. So if it's not paid for, it's much more limited. Now, there are some places in Minnesota, for instance, where a lot of the original work was done. Some of the insurance plans up there contract directly with the large radiology groups and pay for it as a screening measure. But across the country, it's very hit and miss. But I do think that it offers an additional option for people who are unwilling to go through colonoscopy, unable. Now, the thing is, though, that people often have this perception, oh, well, I don't want to have a colonoscopy, but I'll just go lay down and have some pictures taken. What people don't realize is the prep is exactly the same. So you think you're getting away with something, but you're really not. Because the prep is what people don't like about the colonoscopy, ultimately. You've got to do the same prep because you have to have a clean colon right now. Other questions?
Dr. Brooks?
Yes.
When might it be indicated for, in the absence of a polyp or adenoma, to do a little biopsy during a colonoscopy?
And oh, well, there are sometimes just abnormal looking things you see. It's not a polyp, or it's not clearly a polyp. The thing is, we've come to understand more about colon pathology, and there are things that don't look at all like a polyp. They just look funny, and they may actually be what are called flat polyps. There's a growing body of evidence about things that aren't typical polyps that actually have a higher cancer potential than some of the more typical polyps that we see. So anytime the endoscopist sees something that looks unusual, they'll take a piece of it. And then there are inflammatory conditions. There are other things that can go on in the colon that you may find in the course of a screening colonoscopy. So there are a lot of different indications for biopsy. One thing that I neglected to mention within my presentation was stimulated by an article that Joe sent me yesterday. It was published just in the last couple of days about colonoscopy overuse. I mean, again, colonoscopy is a good screening tool, but it's a relatively scarce resource, and every colonoscopy that's done unnecessarily means maybe somebody else is not getting one, or at a minimum it means we're wasting resources because it's fairly expensive. The study that Joe shared looked at the Medicare database and looked at colonoscopies among older people and estimated that anywhere from 20 to 30% of colonoscopies done in people over 75 were unnecessary and maybe medically contraindicated. That's a lot of wasted resources that Medicare is paying for. There have been other studies that have shown that people with advanced cancers, people with advanced prostate cancer, advanced lung cancer, people who are going to die within, at times maybe months, certainly within a year or two, a significant number of those folks are still getting screening colonoscopies. So it's important to keep in mind that there are some patients for whom a screening test really of any sort doesn't make sense. The ACS recommendation around screening in general is that screening should be reserved for people who have at least a 10-year life expectancy. That is, they don't have major cardiovascular disease, they're not on dialysis, they don't have advanced cancer. So there's no reason to expect that they're going to live less than 10 years because most screening tests, the outcomes from those are many years in the future. All right. Well, thank you all for your attention and for hanging in. And again, to those of you on the phone, thanks for joining us. Those of you on the webinar, sorry you couldn't be here.